All right, so let's talk about these congenital urinary disorders. Very interesting things. One called the polycystic kidney disease. All right, these are genetic diseases. There's a strong correlation with people with these, and I'll show you pictures of it. The kidneys have all these cysts all over the kidneys, way too much, and it starts obliterating the rest of the kidney. It starts pushing the nephrons out of the way. But there is a strong correlation with someone who's got polycystic kidney disease and also buried aneurysms in the brain that we talked about with strokes. These can burst. Most people don't know they have these. So if someone had polycystic kidney disease, the next test, one of the follow-up tests they want to do is a CT scan of the head, or at least an angiogram of the head, to make sure there's not a buried aneurysm there, because if that bursts, you're going to have instant death, basically. Okay? Same thing with mitral valve prolapse. So if someone is more diagnosed with mitral valve prolapse, one of the tests they want to do is get an ultrasound of the kidneys, make sure that's fine. Okay? 10% of patients with CRF, which is chronic renal failure, actually have polycystic renal disease, or kidney disease. Okay? Like I said, they're big, large cysts that occupy a lot of space of the kidneys. Now, in one kidney, there's 1 million of these nephrons in there. So when you have a lot of these these occupying space areas of cysts, they're going to be pushing and obliterating all those nephrons, and those nephrons aren't going to be able to function. All right, which means you're going to go into renal failure. All right, so that leads to renal failure. Now, there's 2 types of polycystic kidney disease, basically an adult form and a childhood form. Okay, in the adult form, these are, again, this is a genetic thing, so autosomal dominant. It presents with, see here it is, hematuria, okay, and hypertension, usually around 30 or 40 years old. Okay? They usually have a good prognosis as long as they get the kidney transplant. Okay? Then we have the childhood polycystic kidney disease, and this one presents at birth. Now this one's worse because they end up also getting liver cysts. And the cysts are so bad that you start getting scar-like areas, creating a cirrhotic liver. And these children don't last long, usually about 1 or 2 years old. It's got a very poor prognosis. Okay? So this is what it looks like. All right? Polycystic kidney disease. See all these cysts, it looks like all bubbles on here. If we slice it through a coronal cut, this is what it looks like inside. It starts, they're huge, these cysts, and they're kind of pushing the nephrons off to the side. They're kind of obliterating all the nephrons, so the nephrons aren't going to work. And it causes renal failure. Like I said, 10% of chronic renal failure is due to polycystic kidney disease. Okay? Questions on that one? Then we have this horseshoe kidney. And what it does is that it happens in embryogenesis, and the kidney themselves, the 2 kidneys, are fused on the inferior poles. And it creates this horseshoe-like shape. It's an anomaly, meaning that most people don't even know they have it unless it's an incidental finding for some reason. Anomaly means that there's something wrong with the anatomy, but it does not affect the physiology. Okay? Does that make sense? That's all that is. And it's not an abnormality, it's an anomaly. Okay? Now, the only thing, there's no really complications, but for some reason, which we don't understand, for some reason, they're more prone of getting urinary tract infections. That doesn't mean that there's anything wrong with the physiology of the kidneys. It just means that they're more prone to getting urinary tract infections. And this picture here is also showing a pelvic kidney, an ectopic kidney, where one kidney could be down in the pelvis area. And that's also an anomaly too. Okay? Questions on that? All right, interesting stuff. All right, so let's talk about voiding issues. All right? So urinary retention disorders. This is where the inability to void due to any kind of cause. We call this urinary retention. It could be due to multiple sclerosis. It could be due to a medication side effect. It could be something obstructing the ureter, which means that the urine can't get past there, which means the bladder's not going to get urine, which means you're not going to pee, okay? So that's urinary retention, if there's any cause of it. But then there's also something called a neurogenic bladder. And that really is retention of urine, except the only reason for it has to be a neurological reason. All right? So it could be due to a spinal cord injury, multiple sclerosis, Parkinson's, okay? Anything of that cause. All right? So whenever you hear neurogenic bladder, think of retention, but it's caused by some neurological reason. Okay? This one could be anything, all right, including neurology. All right, then we have urinary incontinence disorder, okay? And this is about 30% of elderly women and about 20% of elderly men. More women than men on this one, okay? We see it a lot. So what we have over here is, well, one type, the most common type, is urge incontinence. This is our so-called overactive bladder. Now what happens here is that the detrusor muscle sits around the urinary bladder. It's a smooth muscle that contracts the bladder that you have no control about. The only thing you have control about is the nozzle. So you have this balloon, and the nozzle, there's a sphincter around it, which you have control about. If you open up the sphincter, then that's going to allow urine to go through. And how does it go through? Is because once that opens up, once you open up your sphincter, now the detrusor muscle is able to contract normally to push out all that urine. You don't think about it, you just say thank God for gravity and just let it all go, okay? But in this case, what happens is for some reason it's going to squeeze. It's like same thing with your heart, it has that premature atrial contraction. For some reason it just squeezes and you didn't have any idea that it was going to squeeze, and then urine comes out. It just does that. This is that the detrusor muscle is hyperactive. And we have medications that will make that less active. The medications, you've probably heard about them. Detrol. And where are they getting the names from? From the detrusor muscle. All right? I won't ask you about that, but it calms down those muscles. Okay? So that's what's happening. You get urgency, frequency, and incontinence. That's the most common cause of incontinence. But you also have stress incontinence. Stress incontinence is that you're increasing abdominal pressure, whether coughing, laughing, sneezing, lifting things. You're increasing abdominal pressure, and as you do that, and water comes out, right? Urine comes out. This is usually a complication from vaginal birth, as this big baby comes through here and stretches things and could stretch the urethra area, okay? Or as the women get older, estrogen starts losing, you start losing some of the estrogen, right? Postmenopausal women, all right? The estrogen usually will make that sphincter tight, but what happens is the sphincter around the urethra loosens up because the estrogen has gone away. So that's what happens with that, okay? And that's stress incontinence. Then we have a couple other things, all right? Fistula, all right? We could have something called a vesical vaginal fistula. A fistula, if you remember, is an abnormal canal between two tubular structures. The structures, and I'll show you pictures of it, the structures we're talking about, vesico is bladder, vaginal is vagina. So there is a connection, an abnormal connection between these two passageways, okay? That means some of the urine is seeping through and going to the vagina, and urine is coming out of the vagina, all right? We also have something called a cystocele or vesicocele. And in this case, the bladder itself, the urinary bladder, is you have a weakened vaginal wall. And what happens is the urinary bladder is now being able to fall into the vagina. And what happens is it develops like a pocket of urine that could sit into the, now the urine is actually in the vagina, but it sits in this pocket from the urinary bladder. I'll show you a picture so you can see it. So you have this bulging of the bladder that's sitting in there. And it could either cause urinary retention, because you think that you empty the whole bladder, but there's water or urine that's sitting in there. Or it could cause incontinence, because when you get up, that extra urine could just slip, slip on out of there. All right, so I'll show you pictures of this so you can see it. So this is a fistula, vesicovaginal fistula. So here's our pubic bone, sagittal cut of the woman. Pubic bone's over here. Here's the urinary bladder. This is the urethra, the outside world. Here's the vagina, and here's the rectum. So there is an abnormal connection between the vagina and the urinary bladder. Okay? Usually cancer can cause this, any kind of surgeries can cause that, a few other things. So now, if there's urine in here, it could seep out into the vagina, and you don't have any control about that. There's no sphincter there to hold in that urine. Okay? This one, pretty busy, but it's trying to show you the same thing. Here's our urinary bladder, there's the vagina, and here's the rectum. And there's a connection, abnormal connection between the urinary bladder and the vagina. That's a vesicovaginal fistula. You could also have something called a rectal vaginal fistula. See that? So now some stool can actually come through here. You see that? So how can that happen? Well, let me give you an example of my sister. She delivered a baby, my nephew is now like 15 years old, 15 years ago. And he was a big baby. So they had to, they delivered him, but he was a big baby. He came out, they had to do an episiotomy, which means they had to open up the introitus of the vagina bigger. And when they did, no big thing. The vagina is a very fixable organ, all right? So we could fix that all up. But what happened was, my sister, I was talking with her like 6 or 8 weeks after delivery, and I said, it was a pretty big episiotomy. Went into the rectum. So, so I said, everything was going good with down below. I said, yeah. Now this is like 6 or 8 weeks later. She said, it's just kind of weird that, like, you know, there's a little bit of stool coming out of my vagina. And she laughed. I said, well, that's not the way it's supposed to be. Yeah, I want someone to go, and this is over the phone. I'm diagnosing stuff over the phone. I said, I want you to go and get yourself checked, you know, to see what's going on. Now, it's not a lot. It wasn't just like a little, like almost like a small, like diarrhea coming out, like a little watery stuff. So they went in and they saw a little pinhole that was happening way in the back. They were supposed to fix that all the way up, and they left a little area there that was left over there. Easy thing to fix. You just make another episiotomy under anesthesia. You make another episiotomy and just close it up, and it was fixed. All right? So that's what happened. So I made that little diagnosis over the phone. Kind of an interesting thing. But now she's fine. She's fine. No big thing. She'd have to pay for it. You know, doctors. I wouldn't say doctor's fault, but it's a complication if you don't see it over there. All right. So that's basically what happens. All right. So we have these fistulas, little abnormal connections between them. Okay. Now this is a cystocele, and a cystocele is this. You're going to have, again, here's your urinary bladder, here's the vagina, and here's the rectum. Okay. Now what happens is part of the urinary bladder is going to be pushed into the vagina. And it creates that, well, here's the same thing. All right, so here's the urinary bladder, the urethra. Here's the cystocele that's actually going into the vagina here. Does that make sense? So you have this little pocket. So she thinks that she's emptying her whole bladder, but there's an area here that fills up with urine. And you can't empty that. Okay, so there could be retention of urine there, or when she gets up, some of it can now slip on out of here. Does that make sense? So that's what this is. We can fix that. And we ask the patients, we always need to ask this kind of stuff, because sometimes as women get older, we ask them, is everything going well down below? You know, no, everything's fine. It's an embarrassing thing, but you know, I'm in the field where like I could ask these kinds of questions, and I want to because I want them to feel better with themselves. So I would ask specific questions. I wouldn't just say, is everything going on well down there? You know, in terms of like, you know, you're peeing and stuff. I would be more like, you know, so what? Do you have any problems when you cough? Is there anything when you get out and urine comes out? And a lot of times, unfortunately, they would say things like, oh yeah, but that's fine because I'm getting older. I'm like, no, that's not fine. We can fix that. Because a lot of times, you got to think of quality of life. You know, when they have this urine that comes out, they smell, or coffee, or mildew, or whichever it is. And they're embarrassed by that. And they don't want to be with their grandkids because they have that smell. They don't want to go to the movie theater with their grandkids and they smell like that. They're embarrassed. And the grandkids are embarrassed for them too. You know, and they don't want to be. So we can fix that. That's definitely fixable. And then the quality of life is so much better. And it's a same-day surgery thing. All we're going to do is tighten this up so we can push it up. It's an easy thing to fix. But don't let the patients think that that's a normal thing. Ask them, do you, and a lot of times when it's sticking out like this, I know it sounds crazy, but they've told me this where, oh yeah, I empty my bladder, but I have to put my fingers in the vagina and push up, and the rest of the urine comes out. And they just think that's a normal thing as you get older, and it's not. Same way there could also be a rectocele, where the part of the rectum's going in there instead of the bladder. They say, oh yeah, no problem. I got to push put my fingers in the vagina and push through the back end to get the rest of my stool out. And they just think it's normal as you get older that this happens. And it doesn't have to be. That's the quality of life. That's not, you don't want to do that as you get older. So it's important as a medical professional to be more precise about your questions. Don't just ask everything going well down there. Oh yeah, no problem. And just, ditch it off. Just be more specific. You're a medical professional. They'll respect you by asking those questions. But, we're all working together as nurses and MAs and doctors really for the patients. The patients are our clients. So we got to make sure that they're, they're Hippocratic oath type thing, right? You want to do better, not cause any harm. But ask specific questions. Any problems with your water work? I'm saying in terms like you go, you don't cough, be more specific. All right? I'm sure you would want to be the same way too after you get older. Right? You don't want to do that. You don't want to smell like urine. And inside, when they open it up, when you open up the vaginal lips over here, what will happen is you'll see the cystocele just fill up. Sometimes I'll do this and I'll literally do this over here and ask them to cough. And when they do, you see urine coming out. So I already know, let's go further, let's do urine dynamic testing. Because obviously she's saying nothing's coming out, and you definitely can see urine coming out. And we can fix that. They might be too embarrassed to talk about it. Right? Right, when you get older, don't you want to be with your kids and grandkids, and you don't want to smell like urine in the movie theater and the recitals and stuff? Right? Quality of life.